The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case. Hi, and welcome to the Allo podcast by the Allo Hope Foundation. I'm Molly Sherwood.
And I'm Bethany Weathersby, and I've already been talking to Molly for at least 3 hours this morning. Are you tired of me yet, Molly?
No, 0% tired. We just had to finish fine-tuning the script.
Okay, good.
As usual. And we were down to the wire. So we were just like, literally reading out loud to each other on Zoom while we're changing in our closet. Because now that we're also recording video on YouTube, for all those youngins who like the YouTubes for their searches, we actually, now we have to put decent shirts on now.
Yeah, it's not just the shirts, though. They're looking at our faces. So that's been a problem for me. Because you know how I like to skip a few days of the showers. So...
you really can't tell. It's fine.
I mean, life with 5 kids. All right. So, speaking of shirts, though, we need to start wearing our merch because we have merch now.
Yes.
Right?
We need to start wearing our merch.
Yeah.
We'll link to our merch. The designs are so pretty. Katie put a lot of work into it, and all the profits do go to the foundation. So for our listeners who want our awesome merch, they should get some. We will link to it. But also, if you want to just donate to the foundation, please also do that. Yes. That is very useful to us.
Very important. Yes.
Okay, we've been wanting to do this episode for a long time, and I think a portion of our listeners are craving more of a discussion about this situation. It's often overlooked because these babies are unlikely to have significant HDFN, but you know that 25% of alloimmunized pregnancies are low titer pregnancies. That does exclude KEL pregnancies because right now, based on the information we have, there is no below critical titer for KEL because any titer warrants monitoring with MCA Doppler ultrasounds for KEL pregnancies. So this discussion is for pregnancies for any antibodies other than KEL where the antibody titer is below 16.
So if anyone is just starting off with this episode because you have a low titer pregnancy, going back and listening to the first 3 episodes of season 1 will probably be really helpful to just give you the basic information that you need to understand pregnancy, treatment, and monitoring. And I also want to add that you said 25%, Molly, are low titer pregnancies, around 25%. But I think a lot of the pregnancies that are not in that 25% that are critical, they actually started off low titer, below critical pregnancy. And so it can change at any moment. And we want to make sure to share about that aspect of the disease today too.
Totally.
And we're actually going to introduce a really, really amazing mom that we've been working with and supporting and just become dear friends with. And her name's Amanda. She started her anti-D pregnancy with very low titers, and those titers quickly transformed into a sudden emergency situation.
Yeah, I am always just blown away and struck by the miracle of Amanda's story. So I'm really excited that we're going to share it. And we're going to share it cliffhanger style because we're going to share her low titer portion of the story in the end of this episode. And then we will cut. And then we will share the rest for our final episode of the season, which is Incredible Survival Stories, because that's what her story became. So sorry to everyone who has to wait to hear the whole story, but let's just shamelessly admit that we want to keep you hooked anyway. So this also works for us.
Yeah.
Yeah.
Yeah. You guys are stuck with us. But seriously, with Amanda, we really struggled to figure out which episode category best suited her situation because it was just such a shift, mid-pregnancy from low titer to HDFN Survival Story. And so we were like, let's just split it up and put it into 2 categories that work best. So we are really excited about sharing her story. And then we also have other stories to share from other moms that had low titer pregnancies too. Mm-hmm. Oh shoot, that's just me. I'm sorry.
Still
I keep thinking
you.
it's going to go to you next.
No, go in. You're just roll with it.
Oh man, I'm rolling. All right. Okay. One thing that I want to say before we start talking about management that I think is really important is, well, I've already had 4 sensitized pregnancies, and all of them were extremely high titers. I've never had a low titer pregnancy. I don't know what that feels like, but I do feel very strongly about close monitoring in low titer pregnancies. In fact, I think that the monitoring is just as important in low titer pregnancies as it is in a pregnancy like mine, where the titers are super high. And I think that the main difference between these two, like high titer, low titer pregnancies, is that you're doing the monitoring for 2 different reasons. I mean, the main reason in the end is to keep your baby safe, obviously. But in our case here with the low titer pregnancy, we're monitoring closely to see if the baby becomes critical, if the titer becomes critical, and then we need to move to MCA Doppler scans to monitor for fetal anemia. So that's what we're looking closely at, and that is it needs to be timed carefully and proactively. And so when there's a super high titer pregnancy, you're monitoring to see if that baby then needs an IUT. So here, what we're looking for is the titer high enough to warrant MCA Doppler scans to monitor for fetal anemia? So just wanted to point that out. But it is super important to have proactive monitoring in a low titer pregnancy.
I really, as a low titer mom, hearing you say that, knowing what you've been through with such high titer and high intervention pregnancies, it's very validating to know that you feel that way. And I think it should be, I'm sure that other low titer moms feel the same way hearing you say that. So thank you. And it's really important.
Oh, good. Of course. Yeah.
Okay. So before we launch into stories, first, let's walk through what disease management typically looks like for a mom whose titer remains low her whole pregnancy. And usually you're the queen of experience here. But guess what? Today it's me. I am the only one of the 2 of us who has experienced this.
I love it.
And my titers never went above 4.
I'm happy.
Yes, I know. It must be nice.
I'm happy to not be the expert.
I know. And I've shared my personal story on season 1 of the podcast. So anyone can go back and listen to that too for more context. So now I can finally speak from personal experience here.
Yes. My brain cannot fathom a low titer pregnancy. Mm-hmm. I don't even know what that would feel like. All of my titers have been in the thousands. So,
yeah.
So a lot of very crucial facts about this that I don't know. And I'm really excited to ask you about that.
Oh, man.
And
okay.
kind of pick your brain.
We'll see.
Okay. So let's look at just how a typical management of these pregnancies. How does it look? So we're looking at diagnosis, and that starts the same way as it does for, any titer. It starts with the first trimester antibody screen coming back positive. And sometimes you do find out in other ways, of course, before you're pregnant. But as soon as it comes back positive, the lab should then identify the antibody. Which antibody do you have? And then get a titer. And just a quick reminder that the titer is the level of antibodies in the mother's blood. And so for this to be a low titer pregnancy, we're talking about antibodies other than Cal, like you said, with a titer that's lower than 16, because that's the critical threshold, the cutoff. Mm-hmm. And I kind of think that at this point, no matter what the titer is, when you get that positive antibody screen, it's time right then for the mother to start her own research and start looking for other women who have experienced this, reach out, try to find support, and really start educating yourself. And I think she needs to learn what to expect for monitoring and for the neonatal period after birth. And she also needs to know how to figure out what her baby's antigen status is. So does her baby have the antigen that matches the mother's antibodies?
Yeah. And finding out the baby's antigen status is something that we covered pretty thoroughly in our second episode of season 1, and also a little bit in our episode for OBs in episode 2 of season 2. Okay. But basically at this point, the mom and her doctor need to figure out if the baby has the antigen that the mom's antibodies match, because that might result in the baby having HDFN, hemolytic disease. So if the mom, for example, has anti-M, we need to figure out if the baby has the M antigen. And if the baby doesn't, then there's no issue here in this pregnancy and it can just carry on as usual. But if the baby does, or if there's not a certain way to determine whether the baby does, then monitoring needs to continue.
Right. And I think that one thing we hear often is, well, how do I find out my baby's antigen status if I can't use the cell-free fetal DNA because I don't have one of those specific antibodies that they can test? So the cell-free fetal DNA can test for, D, E, big C, little c, Kell, and Duffy, which is FYA antibodies. So those are the only ones that they can test for your baby's antigen status. So what if you do have anti-M, like you said? So the only way for sure to figure that out is to do an amniocentesis. But I do think that that should be totally up to the mother and what she feels comfortable with, because an amnio does come with some, like a small risk of complications. And also, the invasiveness of putting a needle into the uterus can potentially increase the antibody titer. So as always, I feel like the mother should be given all of her options and then she can choose what she feels best about.
Yeah, and this is really a tricky choice. So no consistent agreement on this, but the decision depends on the mother and her provider's comfort. So if the mother's titer theoretically does quickly become critical and she proceeds to have MCA Doppler ultrasound scans to monitor for anemia, and then the baby does start to look sick and they need an IUT, some doctors will first want confirmation of the baby's antigen status by either cell-free DNA or an amnio before they do an IUT. Some don't require that, and they will do an IUT without that confirmation. So having that discussion with your doctor is an important strategic preparation that you need to do, even if you're a low titer mom, to anticipate how you'll handle that change together if the titer changes quickly.
Right. I'm so glad that you said that, because it shows that the timing is very critical, even in low titer pregnancies, to get these things figured out early on so that you're not in a sudden emergent situation where the baby's anemic and there's little time to treat. So getting all of this planned out in the beginning is great. And on that note, I want to add that it is very important to get a referral to an MFM or a perinatologist, even if you have very low titers. And we've talked about this before, but some women prefer to be managed by their OB if they have very low titers. And I think even in that case, it's important to still have at least one appointment and conversation with an MFM and establish care with them and prepare for that scenario of what if the titer jumps up? What if the baby does need an IUT? How will we handle it? And then making a plan for that. And so that involves talking to your MFM about how they perform IUTs and deciding if they are experienced in performing that procedure. And then if you don't feel good about it, or if they say, I don't do these very often, talking through a referral plan, like, okay, if this happened, who would you refer me to? And getting all of that set up just in case. So, all right, let's say there's an alloimmunized patient and she has a titer of 4 with an antibody like big E, okay? And we've determined that the baby is antigen positive or could be antigen positive. So then our main plan of action is following the antibody titers closely, right? And that needs to be done every 4 weeks in the first and second trimester, and every 2 weeks in the third trimester. And this has always baffled me as someone on the other end of the spectrum looking over. I'm like, I'm used to weekly MCA Doppler scans. So waiting 4 weeks between titer checks feels like so unnerving. And why do they wait 4 weeks between titer checks when it could change in like a couple of weeks?
Well, first of all, I don't have an answer, but let me agree that it's extremely unnerving. Like, just knowing that I'm only being checked once a month. I mean, I would have it on my calendar and I'd be counting the days. But I think I would imagine it's one of those scenarios where it was researched doing it this way. There's papers doing it this way, and it was okay. Like, there were very few issues of babies falling through the cracks in that spacing. And so people are just going with what's been done before because that feels safe.
Okay.
But I mean, have we ever investigated whether if we moved it to 2 weeks all the time, we had, faster referrals, better outcomes? Right. I don't think we've ever looked at that. If we could, and we could prove it, then titers every 2 weeks would be awesome.
That's what I would prefer.
Me too.
Okay, that's a pretty good answer.
That's, just my guess. But I do wish that'd be cool. Maybe we should do that one day. That'll be another thing to add to our research plan, is like look at what really happens if you draw titers every 2 weeks instead.
Yes.
Yep. Okay. So also, though, for monitoring, there is something that I think OBs and MFMs refer to as doing fetal assessment. And that means doing non-stress tests and biophysical profiles. And that's indicated in all alloimmunized pregnancies where the baby is or may be antigen positive, starting at 32 weeks gestation. So even for the low titer moms, they should be planning for this. And so the non-stress test and the biophysical profile is where you kind of place the heart rate and a movement monitor on the mom's tummy for about 20-40 minutes, make sure the baby is doing things, breathing and movement activities that they should be. And then they couple that with the biophysical profile, which is an ultrasound that checks on baby's overall well-being, and they need to do some certain movements and behaviors to confirm that the baby's doing okay. That's not the same as an MCA Doppler ultrasound to check for anemia, but it is kind of a standard, more broadly applied way to check on the baby's well-being.
Mm-hmm. Okay. And a question we get all the time is, when do I deliver if I have a low titer? The guidelines are a little vague here, but we go based on expert recommendation and also the ACOG, American College of let me try it again. And we go by ACOG, the American College of Obstetricians and Gynecologists. And they don't specify this very directly in their main guideline on management of alloimmunization, but then they do have a resource which we will link here, and it's called Medically Indicated Late Term and Early Preterm Deliveries. And in there, it explicitly says alloimmunization, at-risk pregnancy not requiring intrauterine transfusion, delivery should be at 37 to 38 weeks gestation. And so we consider any alloimmunized pregnancy where the baby's thought to be antigen positive or could be antigen positive to be an at-risk pregnancy regardless of titer.
I'm so glad you laid that out because that comes up all the time. That's something that patients with low titer pregnancies have to advocate for a lot. And now I want to talk about post-birth management. So what's so interesting is just because these pregnancies don't require any treatment during the pregnancy doesn't mean they won't require management and treatment after birth. So in our population, when we surveyed our allo moms, I'm hoping we can publish on this soon, but 48% of those moms with low titer, below critical pregnancies, 48% had their babies needing phototherapy. 14% of those babies still needed a transfusion after birth, and 19% still ended up in the NICU.
Wow. Mm-hmm. Those are some pretty intense numbers. Wow.
I know. Not what you would think.
Hearing, right. But hearing those numbers really gives perspective on what this could look like post-birth, because it is easy to think that, oh, they didn't need intervention, they have a low titer all pregnancy, and then we think, oh, it should be just smooth going after birth, and a lot of times it's not. And I think that a lot of alloimmunized mothers struggle with this post-birth because, well, maybe during pregnancy too, is just they struggle with the provider taking their concerns seriously and taking this disease seriously enough to provide close monitoring. And it can feel like an uphill battle to have to explain to your neonatologist or your pediatrician, explaining that your baby needs closer monitoring, even though you have a low titer. That can be really exhausting.
Yeah, we definitely saw that theme among the moms who shared their low titer pregnancy stories, and I felt the same way myself.
Yeah.
I think all alloimmunized mothers and their providers need to anticipate a potential need for intervention in the neonatal period, and they need to follow the same things we suggest for after-birth monitoring that we talk about in the end of season 1. And we're also going to do a Q&A with Dr. Tim Barr, who's an incredible neonatologist, later this season. So a lot of that stuff will still be relevant to these low titer moms.
Yeah, I can't wait to talk to him. I really like him. And I think our listeners are going to like him too.
Oh, yeah.
Okay, another thing that's a little tricky for these moms is most of the time, I think the babies are born and they look really great. They look good and their coloring is good. And then often there aren't signs of high bilirubin or anemia, and then they're discharged and they think the story's over and they're out of the risk zone.
Yeah.
But that's not always the case. And so the advocacy on the mother's part has to continue all the way to the pediatrician. And from the past few years of experiencing this disease and patient advocacy, a lot of times our disease is not fully understood by the MFM or the OB.
Yeah.
Or even the neonatologist. And so imagine how infrequently the pediatrician sees this disease and how that can be a struggle to understand such a complex condition.
Totally. Like, think about everything pediatricians are treating. Chances are they do not know how to manage a baby with HDFN. And that's not their fault. So I think when you're looking for a pediatrician, honestly, you should be finding one that is just willing to follow your lead, which is sad to say because the burden shouldn't be on the mom, but it's at this point in time, probably the most realistic expectation. So you, the patient, the mom, you will bring them the resources and tell them that bilirubin needs to be checked daily for a week or more after the baby is out of the hospital until it's consistently trending downward. And you need to keep checking hemoglobin and hematocrit for really, what do you say, like 6 weeks? And then until it's been trending up or it's stable for 2 consecutive weeks. So that might be something that you educate a very open-minded, collaborative pediatrician on. And so that's, I think, what you're looking for in the pediatrician that you're going to engage with after your baby is discharged. All right, let's recap on key aspects of managing a low titer pregnancy. 1, determine the baby's antigen status if possible. If not possible, assume your baby is antigen positive and monitor accordingly, and work with your MFM to make a plan as to whether getting an amniocentesis to identify the baby's antigen status is important. 2, which kind of flows with this, establish care with your MFM and determine upfront if that MFM is the right person to do intrauterine transfusions if the baby's disease does progress unexpectedly. If not, it doesn't mean you have to switch right away, but have a referral plan set up where you know who you're going to if the situation changes. Number 3, check titers every 4 weeks in the first and second trimester, and then every 2 in the third trimester. All right, number 4, weekly fetal assessment, which is non-stress tests and biophysical profiles beginning at 32 weeks. Number 5, deliver at 37 to 38 weeks. And number 6, follow all neonatal recommendations, even if your baby didn't need any intervention.
Okay, so now let's transition to some patient stories, which I'm very excited about. And we asked alloimmunized mothers in our patient community if they wanted to share their low titer pregnancy stories for us to share on the podcast. And we loved every single response. And we read all of them. We talked about all of them at length. So let's start with Victoria, and she's a mother in the US. Her first sensitized pregnancy was her second pregnancy. Her anti-D titers stayed below critical, but then they spiked to 128 at almost 36 weeks. And her MCA Doppler scans were showing the MOM values trending upwards. So the decision was made to deliver the next morning. Her daughter had jaundice, hyperbilirubinemia, and then she ended up needing a blood transfusion at 7 weeks. So now she's a healthy 6-month-old. Even with her positive outcome, Victoria says, looking back, that she wishes she had switched to a bigger hospital right away because her local OB did not have experience with alloimmunization. And Victoria's advice for low titer moms is, quote, advocate. Line up a special hospital delivery with a level 3 or 4 NICU just in case. Have your blood typed and screened and have matching donor blood ready for delivery just in case. Most people will not understand this special circumstance of alloimmunization unless they actually go through it. But the Allo Hope podcast and Facebook group helped tremendously because of this, and I didn't feel alone. Oh my gosh. So
my
nice.
heart. Oh, I love it so much. We did not make that up. She just offered that wonderful gem.
This is so kind.
Thank you. Oh my gosh, that's so great.
Yeah, thank you, Victoria. Wow, I'm so glad your baby's okay.
Yeah.
Okay, your turn.
And transfusion at 7 weeks old, by the way, that's so important that she did the follow-up monitoring for that long, right?
Right. Oh my goodness, for sure.
Okay, next mom. This mom is Christina. She actually just had her little girl. Christina has anti-D. Yeah, she had her like a week and a half ago, I think. She has anti-D.
Congrats.
Yes. She had low titers her whole pregnancy. She had a lot of frustrations in her story with her MFM being resistant to monitoring, not wanting to recheck her titers. That happens a lot. And the MFM's partner in the practice actually agreed to do MCA scans. But her main MFM didn't. And this created a lot of stress for Christina because the MFMs were disagreeing about her care and she couldn't get consistent care at her center. So knowing MCAs aren't really necessary for her situation, but also her doctors wouldn't draw her titers, she felt stuck in a situation as her pregnancy neared the due date because she felt like she didn't have anywhere to go. And her OB was no help. She brought this information to her OB and he admitted he didn't agree with the MFM, but also didn't feel comfortable pushing back. And so her daughter was delivered at 38 weeks. And as of right now, she is getting her bilirubin checks and labs that she needs, thanks to Christina's advocacy. And she did need a day, I believe, under lights so far. Right now, her labs are for hemoglobin are slowly trending kind of downward, but it might be transfusion time soon. Looking back, Christina wishes that she had selected a different care team from the beginning to save her from the stress and the conflict. Wow. And her advice is become informed. This is one situation where just trusting and hoping that your doctor has all the information is sometimes not enough. Education saves lives. You are your baby's #1 advocate, and there is no shame in being politely strong and speaking up for what you need during the pregnancy. Also, be mentally prepared for a marathon, not a sprint. This condition means that you are constantly holding your breath until the next test, the next scan, the next titer. It's important to have coping mechanisms and a good support system like this group.
Wow. I feel empowered just hearing that. That's amazing.
She really did such a good
great
job
advice.
She's really been advocating for her daughter. Yeah.
Yeah. And her daughter is so cute, by the way. Just have to add that.
Yeah. Okay. Next mom. This is Cheyenne's story. She lives in the U.S. and in her first alloimmunized pregnancy with anti-E, she was never actually even told she had the disease. Her doctors ran blood work on the father, but never told her what it meant. When she asked questions, her MFM gave very vague answers and even said her baby could die. Never mentioned HDFN. She didn't have titers checked. Oh, I'm sorry. She did have titers checked, but not knowing much beyond the fact that they shouldn't go over 16, and hers never went above 8. So in her third trimester, anti-little c showed up as well with a titer of 1. And she wasn't scheduled at delivery at 37 for 38 weeks, which she now knows that she should have been. Even though at 39 weeks, she says her baby was noted to be lethargic and needed to be shocked during a non-stress test. Have you ever heard of that?
Yeah. Well, I think they just do like a little buzzer.
Okay. Oh,
to
the
get
buzz.
them to move, you know?
Yeah. Okay. She went into labor naturally at 39 weeks and 6 days and gave birth to her daughter and received no afterbirth testing and was sent home after one night. And on the second day, she had I know. On the second day, this is in America, okay? She had a postnatal check, and the midwife noted that she was really yellow. And Cheyenne didn't know to be watching for this because she'd never been told what her disease was. So she went home, and the midwife called her a few hours later and told her to go to the ER because the bilirubin came back and it was much too high. And it wasn't until Cheyenne offhandedly mentioned her antibodies to a neonatologist that the neonatologist was alarmed and was like, "Why didn't you tell me this?" And this is the first time she learned the word alloimmunization. Only then. And then they did a Coombs test on her daughter, and it was positive. And then she had triple light therapy for 2 days and then was discharged again with no further monitoring.
Oh my goodness.
And looking back, she says she's learned so much, and she's so involved, by the way, in our online community now. She said her doctor even told her she couldn't have more children, but now she's pregnant again, and she's having the care she needs, and she feels so much less anxious. And fun fact, she credits the fact that a random Facebook algorithm posted one of your news articles, Bethany, on her page, and she clicked on it not knowing that you guys have the same disease.
That is crazy.
That is crazy. So her advice is no one else is going to advocate more for your baby than you. Use the resources the Allo Hope Foundation provides. Get connected to the Facebook support group. The best providers in the world still have other patients and are only human. You can protect your baby more than you know. She says, I don't feel guilty questioning why we're doing something or pulling up the prenatal chart and asking them to show me the guidance behind why they're making whatever decision is occurring. The care I'm receiving now is infinitely better, and even then, we've changed some of it because of what I've been comfortable with. I am still anxious this pregnancy, but I feel so much more confident, supported, and educated.
That's amazing. Wow, Cheyenne. I love Cheyenne, and what an incredible advocate she has been. And also, I love that she's sharing her story so that she can encourage other mothers to do the same.
Yeah, and we got so many wonderful stories from moms that we had to choose just a few for this episode, but we did still record their stories, and those are going to be available in a separate clip on our YouTube channel if you want to hear more low titer alloimmunized pregnancy stories like that.
So now let's quickly talk about how a low titer pregnancy can change rapidly to a high titer pregnancy. And like we said before, not all low titer pregnancies remain low for the duration. And titers are just so mysterious.
I really do not understand them sometimes. I actually found an article. Yeah, they really surprise me sometimes. And I actually found an article recently that was really interesting about this. So they looked over a 15-year period in their center in Croatia at all the cases where antibodies were undetectable at first, but then progressed to severe HDFN by the end. And
wow.
So I was like, awesome. I wouldn't know the answer to this. So they had 196 pregnancies with anti-D and 159 with other antibodies. So in the anti-D group, 72 of the 196 didn't have a positive antibody screen until the third trimester. And 8 of those
Wow.
that didn't have a positive screen until their 3rd trimester went on to have severe HDFN. In the other antibody group, 16 of those 159 didn't have a positive screen until their 3rd trimester again. And then 10 of those 16 went on to have severe HDFN. So they define that, by the way, as death, IUT, or post-birth transfusion. So this is actually kind of consistent with some circumstances that we have seen of things changing rapidly.
Right. Oh, for sure. And that's really good to see those numbers. I want to read that whole study now. I'm ready to nerd out after this.
Oh,
but
yeah.
And of course we're not telling you about we're not telling our listeners about this to create unnecessary fear, but it is important to be aware that this can happen, and monitoring is super important. Titers can change pretty quickly. Let's talk about Amanda, who we mentioned right at the beginning of this episode. I remember when we first saw her in our support group and she shared what was happening, we really thought that we might be walking with her through a stillbirth. We were so scared. And her story starts off as a low titer pregnancy.
Yeah. I'm so glad she's going to share with us because her story just overwhelms me with gratitude every time I hear it. And she's wonderful. She's a great support to other women in our community, and we just appreciate her so much. But we had to figure out how to fit her story in here. So we're actually going to split it in 2. So right now we're going to cut to our interview with our friend Amanda, and she's going to tell us the low titer portion of her story. And then we'll save the rest of her incredible journey for later in the season for our amazing survival stories that will show the rest of our interview with her. So let's cut over to her interview right now.
Hi, Amanda is here with us. We're so excited to have you on the Allo podcast. Oh my gosh, I don't know what to say. I'm so excited to see you in person. Yeah, welcome.
I am so excited. I'm probably the podcast's biggest super fan. I'm pretty sure I've listened to it the more hours than anyone ever. Maybe
amazing.
not, but I love it so much. I'm so happy to be here.
Well, we're excited to meet you in person because I feel like we know you really well and have had this really intense friendship, and we'll learn more about that later, but it's just so great to see you and talk real time. So this is exciting for all of us.
Such a fan of the Allo Hope Foundation. I've got my Allo Hope sweater on. And I have my little emotional support Allo Hope Proof of Miracles puppy. This is technically, not mine, but it's mine for today.
I love it. Oh man. One day Molly and I are actually going to purchase
Bethany.
our own. We got to get our own merch. Okay. Well, before we dig into your story, can you just tell us quickly where you live and what do you do when you're not in HDFN research education world?
Yes. Oh my gosh. So we live in a little town called Watertown, Minnesota. We're about 45 minutes to an hour from Minneapolis, St. Paul, so the Twin Cities here in Minnesota, which is where most of our medical hub is there. So we're not too far from the medical hub here. And I am a full-time business analyst. My technical title is a business process specialist too. It's easier to just say business analyst.
Not
People
one, but
understand
2.
that a little better.
Love it.
So yeah. So I work for a company called Integris. We're in the semiconductor industry. So most people just kind of give me a blank stare when I say that. Microchips. I don't know. It sounds really fascinating. It's really not really that fascinating at all.
I have the blank stare, and I don't even know what you just said.
Oh, I'm doing that.
I don't know what
now.
you said.
I'm doing that.
Exactly. So, I stare at a computer all day.
Oh my gosh. Wow.
So that I do that full time. I also own a boutique dance studio here in our small town. So that keeps me pretty busy. And then, of course, I am married and I have a now 4-year-old daughter. And I know we already mentioned that I have a survival story. So I also have a 5-month-old son. And we have 2 dogs. So we're very busy over here.
You
And
are
now
Wow.
I'm on the
busy.
patient advisory board for the Allo Hope Foundation.
Yeah. How are you even here, Amanda? Oh my
Oh,
gosh.
we just make it work. It's all good.
Well, we are so glad we get a little piece of you.
amazing.
So this is perfect. Mm-hmm. Okay, will you
Yes.
tell us? Will you tell us how you first found out that you had antibodies?
Yes. So, to back up a little bit, I had a miscarriage, I want to say 2 months before I got pregnant with my Allo baby. So, during that time, I did get the the RhoGAM shot, but it was when I got pregnant with my Allo baby. The first blood draw that we took at like the 8-week appointment is when the antibodies were detected. So we're just guessing that's where it came from, because when we did blood work with the miscarriage, they weren't there. So it just makes sense that for some reason, I was already bleeding when I had the RhoGAM shot. So there's a chance that it just kind of happened from that. The first test, what they found anti-D antibodies, and they were too low to titer. And then the second check 4 weeks later, they detected anti-D and anti-C large, also too low to titer. And at both of those appointments, my OB just told me, she told me kind of what could happen, that, there's a chance that the antibodies could cross the placenta and cause the baby to be anemic, but they're too low to titer right now, so we're just not going to worry about it. And I'm not a naturally anxious person, and so if somebody tells me not to worry about something, I just don't. Which I
That's
know you're both
amazing.
probably so jealous of that.
I am so
I'm
jealous.
So jealous. Yeah,
But
really
at
jealous.
the end of the day, I feel like for the most part, I'm sure that serves me really well. But I think on some regard, that was almost a downfall in this case, because I did zero research. I didn't look into it at all. She
Right.
just told me not to worry about it, so I just stored it away and just didn't even Google it. Not even a single time.
So all you knew about your disease at the time was just what she had told you that day, right?
Yeah, that was
Nothing
it.
else.
That was the extent of anything that I knew about.
You just said you're not naturally an anxious person, but were you nervous to get that diagnosis after the miscarriage? Because I don't know, I would have been more uneasy because I had just had a miscarriage.
Yeah, that's a really good question. I do think that any pregnancy following a miscarriage is just filled with constantly waiting for the ball to drop.
Yeah.
And, I always feel so awful if that's like somebody's first experience ever, because they never get to have that like one pregnancy that was just like fine the whole
Yeah.
time. Because they definitely experienced, you think that as long as I can just get longer than I was last time, then I'll feel fine. So I had my miscarriage at 8 weeks. So I'm like, if I can just get past 8 weeks, then I'll feel fine.
Yeah.
And then you don't. And then you're like, if I can just get to 12 weeks, then I'll feel fine. And then you're like, then you don't.
Yeah.
And you're just like, I just need to make it to the anatomy scan. And it's like, it just continues. So I definitely understand that. But when she mentioned the antibodies, I think because I didn't research it at all, and she just mentioned like could cause the baby to be anemic. And like many people, the only thing I knew about anemia is like, oh, you have low iron. Like I
Yeah.
didn't take it seriously
Right.
at any level of like, this
Right.
could kill my baby. It was just like, something that we would maybe deal with at some point, but I just wasn't concerned about it. So I wouldn't say that the miscarriage caused any thoughts with like, oh, now I have antibodies. I just really didn't even consider the antibodies to be like a thing to think about.
Okay, so your doctors told you about this and then said not to worry. And then was there any follow-up plan?
Good question. So the only real plan at that point was just to check titers every 4 weeks. And I don't think she educated me on this, or I just forgot or wasn't really paying attention on like what a titer was and like when
Right.
that number would be concerning.
Yeah.
It was just kind of like, we're going to check your antibody level every 4 weeks. And if it rises, then we'll talk about that next. And so we didn't really talk about like, if it rises, this is what'll happen or anything like that. There was no referral to an MFM. There was no discussion of that. It was just, we're going to check this every 4 weeks, which is good, right? That's the right path to take. But I wish that I just knew more about what we were looking for every 4 weeks and had a little more education on that.
Will you walk us through when things changed in your monitoring?
Yes. So I was exactly 23 weeks. So I had, let me back up a little bit. So I had my 20-week anatomy scan. And at that scan, everything was looking fine, but they were having a really hard time viewing his heart just because of the position that he was in. And so they were going to reschedule a second anatomy scan to make sure that they got all views of that. Looking back, I'm wondering if part of what happened a couple weeks later is maybe what they were starting to see at that scan. So again, I wasn't really concerned about it because I know that, you know, at 20 weeks, they're still really small. A lot of times you have to have another ultrasound because they're in weird positions. So I wasn't concerned anything was wrong with his heart. I just knew that they wanted to look at it again. And then when I was exactly 23 weeks, I was just bored sitting on the couch and decided to randomly log into my chart account or my medical, you know, like they have all those apps now. So I signed into my app and I was just like, oh, I wonder if I have any like lab work from the last couple weeks that have come through. And I noticed that there was one from probably 3 weeks prior that had come back. And then my doctor had put a note in our chart to be referred to a high risk OB. And that, even as an unanxious person, of course, is going to like spike like, oh, I need to be sent to a high risk OB, like something is wrong.
When was that note put in? Like how long before that was that put in in the chart?
It was, I think, two and a half or 3 weeks before I saw it.
Wow. Okay.
So it was right after probably that would be like my 16-week blood draw. It would make it, I think.
Okay.
Is what triggered her to make the note. But I didn't know how to read the results. So I had never really saw that, you know, the antibodies were checked or what the result was or what that meant. And there wasn't any sort of like flag, you know, like as we know now, when you're checking hemoglobin, you can see like it has a little, when it's low, you know, it has a little red dot or whatever. There was nothing indicating that the number was off. And so, so I didn't really look at that or know what that meant. All I recognized was I was supposed to be referred to a high-risk OB, and that note was put in several weeks ago, and I hadn't received any kind of phone call, neither from my doctor telling me she was referring me, nor from like a high-risk clinic trying to schedule any appointments. So
Wow.
then
So
I
what did
kind
you
of started
do?
like, okay, did I miss something? Did I miss a voicemail? Did somebody send me an email? So I start like looking through everything, not finding any information on it. So I called my OB's clinic, and my OB and her nurse were out that day, but I talked to the OB nurse that was there, said, hey, I just noticed this in my chart. It was like they closed in like 20 minutes. So I called them at like the very end of the day. This was on a Monday. And she was like, hey, let me check for you. She's like, I'm not seeing anything, but let me check with them tomorrow, and then I will call you back tomorrow. And so, you know, I'm just going to bed that night like, I'm supposed to see a high-risk OB. I haven't heard anything. This was put in a couple weeks ago. I'm not sure what's going on. But I'm just wait until the next day. She does call me back pretty early in the morning, which was really nice. I didn't have to like sit on it for the whole next day. And she said, I did see the note. There was no referral sent. So I did go ahead and just send that. They should be contacting you in the next like 48 hours.
That is so terrifying. I don't know how something like that gets overlooked.
I know.
Multiple times.
I try not to like think too hard about it because I know that like people are only human. Like mistakes can be made. Like, it's not like someone vindictively was like, I'm not going to submit this report.
Right. Yeah.
You know, so just try to give it grace and know that like we're fine, but it is like, you know, hard to think about. So I just try to just be like, you know what, hopefully somebody just made a mistake, like it's fine, we're all good.
That is a really nice perspective.
That's, although like I am passionate now about like I want to figure out how to assist in like getting some sort of trigger if a number like that is, or like if there's a referral put in, there needs to be some kind of an alarm in the system, because we are a miracle story, but somebody else with the same scenario would not be.
Right.
And that is awful to think about.
Yeah. I think that's why I have a bit more of a cynical feeling towards it, because for years I have seen this same mistake happen again and again and again. Sometimes it's with the positive antibody screen. It's in the chart, but then it just never gets noticed. Which again, that can happen, you know. There's a lot of different people working together to treat one patient, but it's hard to understand it.
Yeah.
I guess you got a call soon after, right, from your nearest high-risk MFM?
Yep. So I saw the note on the chart Monday, called my regular clinic. Tuesday she called me back, told me she finally did submit the referral. Wednesday, I get a call and they're like, hey, we got the referral. We'd like to see you ASAP. Can you drive to this clinic tomorrow? And it was one that's like probably about 45 minutes away from my house. So it definitely wasn't the closest option, but it was the first available appointment. And so I was like, well, yeah, I'm going to do whatever I need to do. Like, take PTO, leave in the middle of my workday. It doesn't matter. Like, at this point, I know that I need to figure out what's happening, and I'm just going to take whatever they give me, right? So scheduled that on Wednesday. And so I'm 23 weeks, 3 days. And then my appointment was 23 weeks, 4 days. So this was Thursday of that week. And so I go in to the high-risk OB appointment. I did have my husband there with me because I kind of, for some reason, even though I'm not like an overly over worrier, somehow in my spirit, I like knew that whatever was going to happen was going to be a big deal, because before I even went to that appointment, I started video logging like the experience. Like, I made my first video on YouTube before I even went to that one. And I figured, like, if everything's fine, I can just delete this video off my phone. But like, for some reason, my spirit knew like this is going to be something for whatever reason. I didn't know why.
Wow.
That's
and
amazing.
I wanted to document it.
Yeah. And thank God, thank you for doing that, because we don't have many, I can't think of a single woman so far who we've walked with who has thought in those intense moments to chronicle their journey in the way that you did. And I'm so glad we have that resource.
I was like frantically, like, I don't love to read things. I like to listen to and watch things. And so I was like frantically looking for YouTube videos of anyone who has had this experience, and I wasn't finding anything. Similar to what I was Googling, I was just finding like medical videos teaching medical students basically how to pass a test on antibodies. It wasn't any sort of patient experiences or anything like that. And I was like, you know, I don't know why I feel the need to do this, but I feel the need to do this. So we're just going to run with the feeling.
Wow.
So I recorded that first video that right before I left for the appointment, and I had my husband with me because, like I said, I just sort of had like a knowing that like we needed to be together on this. And so we went to the appointment, checked in. They said that it would be about 40 minutes. They said it was like a level 2 ultrasound. They were looking for some specific things. They did not tell me what they were looking for at all. So I didn't have any idea what they were scanning. And so we were in the room, and we're like a solid hour and a half into this ultrasound, and 3 ultrasound techs later. And we can see him And we don't read ultrasounds. He looks totally fine.
Yeah.
Like, I have
Yeah.
no idea what I'm looking at. Right? You're looking at a gray blob. You can see his little heart beating. So you're like, well, he's alive.
Oh my gosh.
Like, we're fine. So we're like an hour and a half into it. And my husband, they go out of the room quick. And my husband's like, can we just leave now? We've been here for like ever.
Do you think you would have felt better if they were just talking you through it? Like,
I don't know. It's hard
Okay.
to say. It's hard to say if that would have felt better or not.
yeah.
So, because of course he's in one of like the uncomfortable like office chairs, like sitting next to me
Yeah.
for an hour and a half. That's a long time to be in one of those office chairs. And so I'm like, because he's like, you can see his heart beating. Obviously he's fine. Like,
Yeah.
can we just go now?
Oh my gosh.
And I was like, babe, I'm sure that they're doing whatever they need to do for a reason. Like,
Yeah.
they're not holding us here hostage for nothing.
Yeah.
So, yeah, I was a little bit confused about why they kept having like more texts come in. They had somebody come in that was like specifically there to make sure that the machine, like the ultrasound machine, was like working as well as possible. And I think looking
Wow.
back, it's because they just like wanted to make sure that what they were seeing was as bad as what they were seeing and make sure that the machine wasn't just like doing something weird, you know? And so finally, after 2 hours, the doctor finally came in, and this, like, I'm sorry, I'm going to get emotional just thinking about this. Oh my gosh.
It's okay. We cry a lot here.
I know, and I cry with you when I'm listening.
Oh my gosh.
She came in, and she sat down and she touched my leg.
Oh my gosh.
And I just knew, like, my heart sunk into my stomach. Like, I feel like especially since COVID, like, people don't just, like, touch you. Like, we've all sort of kept this, like, 6-foot distance.
Oh my gosh.
And so, like, you know, it's you don't even really shake people's hands anymore. Like, even that's weird, I feel like, now. And so, like, when she sat down and just touched me, I just, like, knew, like, it was not good. And it was hard to understand what wasn't good because I didn't know what they were checking. And like I said, I could see his heartbeat. So I'm like, I know he's alive. So you're not coming here to tell me that he's gone. But like, something is not right, obviously. So she sat down, she touched my leg, and that was the first time that somebody explained titers to me.
Wow.
So she sat down and said, so you have antibodies, and kind of went through the normal, like, antibodies, you know, can cross the placenta and attack red blood cells and cause anemia. And she said with anti-D antibodies, we're usually concerned about the possibility of anemia when it reaches 16 to 32. And your titers are 2048.
Oh my gosh.
And
Amanda.
she says, I have no idea how or why you went from too low to titer to 4 weeks later, 2048. But your, you know, body went into overdrive for some reason, and your baby is incredibly sick.
Oh my goodness.
So then she explained what they were looking for on the ultrasound. So first she taught me what the titer was. And then she told me, here's what we were looking for. She told me what an MCA scan is. And then she taught me that, you know, a normal MOM is 1. They're concerned about anemia when it reaches 1.5, and he was 2.4.
Wow.
And then she told me that they also, when, you know, clearly knowing that he was very anemic, the next thing they become concerned about is heart failure and high drops. And so then the other thing they had looked for in the ultrasound was if he was hydropic, and he had fluid all over his skin, all over his stomach, and all over his heart. So he was in active heart failure.
That's so scary.
Which, like, is so hard because I was in there for 2 hours looking at him, and I didn't see that because, like, I don't know Now I could look at an ultrasound and I could tell you what high drops looks like, but at that point I could not.
Yeah. But he was moving around and his heart was beating.
He was moving a little bit, not a ton.
Okay. Yeah.
But we're 23 weeks, so he wasn't like going crazy at all. But after we finally got the first IUT, which we'll talk about in another episode, then I learned what he actually is like when he's healthy and moving.
Okay, yeah.
So then it was clear that he really was not moving very much at that point. I just didn't know.
Oh my gosh.
I didn't know how much he was supposed to be moving at that point.
Wow.
And how did that feel to get that news so suddenly, just out of the blue? How did that feel? Like, what was running through your mind?
I felt obviously just crushed. I felt like we just talked about earlier with any pregnancy after a miscarriage, you're waiting for the ball to drop. Mm-hmm. It was like, okay, here it is. Like, we just proved that the ball has dropped. Like,
yeah.
And so that was hard to like work through mentally. Just like, I have to retrain my brain that the ball is not always going to drop because that was just like such a solidifying moment of like, things are not going to be okay. Mm-hmm. So one really good thing, though, that she did say next was after she explained to me everything that they were looking for and why I was there, she said, I've been watching your scans from the other room, and I've already called a really good doctor downtown. He's going to be able to help you. He's expecting you right now. Can you leave right now and go to him?
That's amazing, Amanda. And you know how we were like kind of ganging up a little bit on whoever missed that note in your chart about the referral? This is like the other end of the spectrum where like
the best
she was just
scenario.
So on top of it.
So on it.
Just handled it, and that's exactly what needed to happen.
And it's like probably 4:30 p.m. in the day now. And so we're at the end of like regular, clinic office hours. But she was able to like get in touch with them, and they were willing to see me, that night, even though I think I got there like right when they closed. So they were waiting for me.
That's
I
amazing.
I can't wait to talk about the rest of it because it's just absolutely incredible. And I just, all of the people that have helped me from that point on are just like so special to me.
I can't keep it together.
So you'll have to hear the rest in another episode.
Okay, before we move on,
Oh
can I just say that when you're describing the way that MFM kind of talked you through what was happening and the basics of the disease and explained everything to you in this really wonderfully clear way. Mm-hmm. I feel grief thinking about how that's what you deserved right at the beginning when you were first diagnosed. That is what you deserved, was to have that information and to be empowered as this baby's mother and to know what was happening with your own body. And I want every alloimmunized woman to have that.
Well, the Allo Hope Foundation is going to make it happen. I believe that wholeheartedly.
Yeah. I hope. We still have a ways to go, but we're getting closer.
I'm like, when I have a free moment in my busy life, I'm like, I just need to go to every clinic within 50 miles of me and teach all the OBs exactly what to do.
Please do. Please.
Send them to the Allo Hope Foundation website. Educate them on things.
Well, you're part of this too,
my
Amanda.
goodness.
Your work is really important too.
Absolutely.
And we really appreciate you.
Yeah. Okay, so let's wrap it up here with this. The low titer portion of your story is now clearly over. So, okay. All right. Should we have Amanda do the closeout for our episode?
Did we?
Yeah, we totally should.
Did you guys mention in the other portion of this episode? Did you talk about like, hey, we're going to share Amanda's story because this is why you have to be checked? Like, don't forget to check the titers.
But actually,
okay.
let's just Let's just keep that in there.
I
Yes,
just realized we
and
didn't talk
say it
about
again.
that, so I just was wondering if you already said it.
You can say, this is your time to say whatever you want about low titer pregnancies. I mean, we did say a lot of stuff, but it's powerful coming from you as you've lived it.
Yeah. Okay. So the other thing that I just want to share and make sure that all the other Allo moms feel empowered to do is always just be checking your titers every 4 weeks. I would personally check them every 2 weeks, knowing, hindsight 2020, knowing what can happen. Nothing happened to me in between those two. So everyone was really baffled on that. I kept getting asked if I got in a car accident, if I had had any bleeding, and nothing happened. So there was no signs. And that was honestly one of the biggest mind trips for me, was like, you think that if antibodies went that crazy, and I'm sure, Bethany, you maybe felt the same way, is like, wouldn't I just like get a rash or something? Like, wouldn't I have something to like
Right.
have my body be like, hey, like something's happening? Like, no, there's nothing. Like, I was totally fine. I was having a really healthy pregnancy. I didn't even have really bad morning sickness or anything like that. And so, if for whatever reason you're having to advocate to your doctor to check titers regularly, A, do that, and B, maybe find a different doctor.
Yes.
Yes.
Very good advice.
Preach.
We totally agree.
Yeah.
Yep. And this
yeah,
is,
I love it.
I was just going to say, this is so important. And that's why we're doing a whole episode on low titer pregnancies, for this reason right here.
Yes. I also wanted to just share for any of the low titer moms that are listening that I just want to validate your feelings. I think that, sometimes I've seen a lot in the, Facebook community that it can be extremely anxiety inducing to be listening to all of these other stories of these kind of like worst case scenarios and be constantly like on the edge of your seat waiting for the worst to happen. And, you might feel maybe a little bit of guilt for feeling so nervous because you're having a healthy pregnancy. And I just want to say that the waiting game has got to be extremely hard. We kind of went from 0 to 100. I didn't really have a lot of that, slowly watching titers rise or anything like that. And so I just want to validate you that if you're feeling really anxious, like, that's okay. And just reach out to the group if you need anything, or if you just want to talk to other moms. Like, you are heard, you're valued. Just because you have low titers does not make you any less of an Allo mom. And I just really wanted you to hear that.
Oh, thank you so much
That
for
is
saying
so
that,
beautiful.
Amanda. I feel like you spoke to me. Like, that really speaks to me in my experience too, because I think a lot of those low titer moms do feel a little reluctant to share their story, or reluctant to just own and accept their feelings, because they don't want to take away from, other women's experience with severe disease. And hearing that from you and Bethany, I know you share that sentiment too. It's very empowering, if I could say that on behalf of low titer moms. So thank you both.
And thank you, Amanda, for sharing the first part of your story with us.
Yes. You'll
Okay.
all have to listen to the, what is the other one called?
I don't know yet.
Great
No.
Survival Stories?
We haven't titled it yet.
Oh,
HDFN
listen.
Survival Stories.
oh
something.
yes.
Yeah.
You'll have to listen to the HDFN Survival Stories to hear the rest.
Yes. Do you know? Okay, Amanda, you probably know the ending spiel that we give every episode since you've listened to them, right? Can you give it? It's
I know,
written.
right?
It's you want to read it? Let's hear it.
Yeah, I'm gonna have
What if
to,
she had it memorized? What if she just belted it out
which
perfectly?
is so funny. I can probably do the beginning, like.
Oh my gosh.
Okay, let me find the document again because I don't want to mess it up. Okay.
You want me to put it? You want me to put it in the chat?
Oh yeah, go ahead and put it in the chat.
I'll just do that.
Oh wait, yeah. Oh yeah, I see you copying it right now.
Oh, there you go. That's it.
Okay, are you ready?
Yeah.
Okay. Whether you are a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website at allohopefoundation.org. That's Allo, spelled A-L-L-O, Hope titerfoundation.org.
That was
for
so
listening.
good. You need to be sorry. You need to be doing this podcast. Also, can you be my life coach? All right. Okay. Release the
Reel it in.
inhibition.
Really?
Okay.
All right.
Feel the rain on your skin. All right. If anyone Stop. I got to be serious.
Okay.